Hello, my name is Giovanna Middlebrook, and I will be presenting my verbal defense SBAR on the diabetes mellitus case. TH is a 63-year-old white male who presents to the pharmacotherapy clinic on September 10, 2016 for diabetes management. The patient has a past medical history of type 2 diabetes with complications, peripheral neuropathy, hypertension, dyslipidemia, chronic lower back pain, constipation, and erectile dysfunction. He no longer uses tobacco as he quit 23 years ago. He drinks a few glasses of wine a month, and he exercises minimally due to his back pain. His father died of a heart attack at age 72, and both his siblings, like himself, have type 2 diabetes. He reports an allergy to lisinopril, which he developed a dry cough with, and to penicillin, which his reaction was a rash. The patient currently takes acetaminophen as needed for pain, amlodipine for his blood pressure control, aspirin for heart disease and stroke prevention, Docusate as needed for his constipation, gabapentin for diabetic neuropathy, insulin glargine, metformin extended release, and pioglitazone as triple therapy for his diabetes mellitus type 2, sildenafil for his erectile dysfunction, and simvastatin for his dyslipidemia. It is important to note that the patient states that he is compliant with his medications. After reviewing the patient's self-monitoring blood glucose journal, I have seen that his blood glucose readings are severely uncontrolled. For the 10th, his fasting was 137, his pre-lunch was 178, his pre-dinner was 206, and his bedtime was 258. His HbA1c has also come back at an 8%, which has led me to assess him with uncontrolled diabetes. The patient also has microvascular complications due to his diabetes. He has peripheral neuropathy and states that he has not seen the podiatrist in 2 years. His albumin to creatinine ratio is also 34.6 milligrams per grams at this moment, which is indicative of microalbuminuria. His latest blood pressure reading was 146/92, which shows that his hypertension is slightly uncontrolled. His lipid panel came back, which showed that his triglycerides are at 210, his HDLs are at 37, and his LDLs are at 110. This is indicative of hyperlipidemia. It is also important to note that his 10-year ASVD score is 31.6%. Further lifestyle modifications are needed due to his weight, as he is overweight, and also, even though he does try a lot with his diet still consists a lot of carbohydrates and excess calories. Now to discuss the plan. For his uncontrolled diabetes, our goal is a preprandial blood glucose of 80 to 130, a postprandial blood glucose of less than 180, and an HbA1c of less than 7%. My plan is to increase the patient's insulin glargine to 48 units sub-Q daily at night, and to add 10 units insulin aspart before his largest meal. My justification are the 2016 American Diabetes Association Standards of Medical Care and Diabetes Guidelines. Alternatively, we can adjust his dose by 10 to 15% once to twice weekly until his self-monitoring blood glucose is reached, or consider adding 2 or more rapid insulin injections before meals. For monitoring, we want to monitor his blood glucose, including hyperglycemia and hypoglycemia, his potassium levels, and his HbA1c. For follow-up, we do want to see the patient back in the pharmacotherapy clinic in 3 months to assess his HbA1c level and his diabetes control. For his peripheral neuropathy, our goal is to decrease symptoms, the risk of skin breakdown, and infections. Our plan is to have improved hyperglycemia control, make sure that the patient is wearing proper footwear, doing daily feet checks, and has a podiatrist appointment. Our justification is that initial management goals include controlling hyperglycemia, which may actually worsen pain of peripheral neuropathy. The patient also states that he had not had a foot exam in 2 years, and per 2016 ADA guidelines, he should be having at least yearly exams, be checking his feet daily, and wearing proper footwear. An alternative is to increase his gabapentin dose from 600 milligrams 3 times a day to 800 milligrams 3 times a day. For monitoring, we want to monitor neuropathic pain, foot lesions, and mood changes. A follow-up should be a podiatrist appointment as soon as possible. For his microalbuminuria, our goal is to prevent chronic kidney disease and decrease his ACR from 34.6 to less than 30. My plan is to repeat his ACR at least 2 more times and help him improve his glucose control. My justification are the 2016 ADA guidelines, which state that 2 of 3 specimens of ACR collected within a 3 to 6 month period should be abnormal before considering a patient to have albuminuria. An alternative is that if microalbuminuria is confirmed, which I do think it will be, I will initiate the patient and will start in 50 milligrams PO once daily. My justification is again the 2016 ADA guidelines, which state that either an ACE inhibitor or an ARB are recommended for the treatment of non-pregnant patients with diabetes and modestly elevated urinary albumin excretion. The patient also stated that he was intolerant to lisinopril. We will be monitoring his ACR, GFR, serum creatinine, creatinine clearance, and BUN. Our follow-up is our pharmacotherapy clinic appointment in 4 weeks for repeat ACR testing. For his uncontrolled hypertension, the patient's blood pressure goal is less than 140/90. My plan is to discontinue his amlodipine and instead initiate him on losartan 50 mg PO daily. My justification for his blood pressure goal is JNC8 guidelines, and the patient will more than likely test positive for elevated urinary albumin excretion. Therefore, losartan is renally protective. Alternatively, if the patient is not well controlled and has already implemented lifestyle modifications for comorbidities, then an increase in his losartan dose to 100 mg by mouth daily would be warranted. For monitoring, we do want to monitor his blood pressure, hypertension and hypotension, renal function, and adverse drug reactions for his losartan, since it will be a new drug. Our follow-up is 1 month with the pharmacotherapy clinic. For the patient's hyperlipidemia, our goals are LDLs less than 100, triglycerides less than 150, HDLs greater than 40, and to lower his LDL cholesterol by approximately 50% or more. My plan is to discontinue his simvastatin 80 mg and instead initiate atorvastatin 40 mg PO daily at bedtime. My justification is that the patient has a 10-year ASVD risk score of 31.6%, and according to the 2013 ACC/AHA guidelines, a high-intensity statin is recommended for this patient. Alternatively, if the patient is intolerant to the atorvastatin 40 mg, a dose reduction to atorvastatin 20 mg PO daily at bedtime is warranted. For monitoring, we do want to monitor the patient's lipid profile, LFTs, and adverse drug reactions, since the atorvastatin will be a new drug. We do want to follow up in a month at the pharmacotherapy clinic. When determining if the patient was a high-intensity statin candidate, I did see that his ASVD risk score was pretty high. Therefore, my goal is to decrease the patient's ASVD risk. My plan is to initiate a high-intensity statin like I had previously talked about, have the patient continue to take his aspirin 81 mg PO daily, and help him better control his diabetes and hypertension. We are also going to go ahead and try to implement more lifestyle modifications because even though the patient is definitely trying to do that, there is room for improvement. My justification is that the patient has a 10-year ASVD risk score of 31.6%, and that better management of his diabetes, hypertension, and hyperlipidemia are going to help lower this risk. Alternatively, there's really nothing we can do except that hopefully get these under control. For monitoring, we are going to monitor the risk score. We're going to monitor his blood glucose, his blood pressure, and his lipid profile. Follow-up is 3 months at the pharmacotherapy clinic to reevaluate his risk score. I do want to help the patient implement more lifestyle modifications into his life, and therefore our goal is just that. I want to go ahead and help him implement the DASH diet, consume less than 2,000 calories per day, which will promote weight loss, less than 1,500 milligrams of sodium per day, which will help with his hypertension, and also have him attempt to perform 150 minutes per week of moderate activity. My justification is that lifestyle modifications would improve the patient's diabetes and his hypertension, his hyperlipidemia, and also lower his ASVD risk score. Alternatively, if the patient's chronic back pain doesn't allow him to fulfill his goals of physical activity even when he's trying to go ahead and do so, an evaluation of his pain management is warranted at his next clinic visit in 4 weeks. We are going to go ahead and monitor his food intake, calories, sodium, and weight loss. And we are going to have him go ahead and keep those blood glucose journals and also have him do blood pressure journals. A follow-up will be warranted in 1 month at the pharmacotherapy clinic. This concludes the end of my presentation. These are my references. Thank you so much for taking the time to listen to my presentation. If you should have any questions, please ask them and I will answer them within 48 hours. Thank you.